Welcome back to Plastic Surgery Decoded, the podcast designed to help you better understand plastic surgery. We take the mystery out of it in plain language. You'll find it interesting and useful whether you are already planning a procedure or you're just curious. I'm your host, Dr. Regina Nouhan, and we are now into Season 5 of the podcast. After you listen to this episode, know that you can explore and enjoy many other topics, either through your favorite podcast app or through the website at plasticsurgerydecoded.com. The first 40 episodes, or Seasons 1, 2, and 3, comprise the Plastic Surgery Decoded Classics, with my singular voice covering cosmetic and reconstructive procedures, skincare, and general questions about plastic surgery. The remainder of episodes, Seasons 4 and 5, are interviews with my colleagues around the country to help you learn about the subject. A great variety to choose from. Remember that this podcast reflects my experience and opinion, as well as those of any guest interviewed. It is not intended to provide medical advice, nor is it a substitute for a formal consultation with your physician. So come along with me as we explore this ever-growing world of plastic surgery. Let's go! When we take the time to think about the function of our bodies and what we feel we couldn't do without, hand function is near the top of the list. The hand is our vehicle to interact with our environment. We use it to feel and manipulate objects, to facilitate our daily activities, and even to feed ourselves. But problems can arise, whether from injury or inflammation from disease or overuse, or many other etiologies. Some common patterns are noticeable when we look at data from patient visits to seek help. Indeed, carpal tunnel syndrome, trigger finger, and ganglion cyst are 3 of the most common hand problems seen by a hand surgeon. That's why in this episode, we have asked plastic and hand surgeon Dr. Christopher Jehle to sit down in conversation with us and share what he finds to be best treatment practices for these 3 entities. He also talks about a fresh new approach to where and how corrective procedures are done. Let's now go to what he has to say. Well, I'm pleased today to introduce Dr. Christopher Jehle. Now, he is a board-certified plastic surgeon in Kansas City. He's also a fellowship-trained hand surgeon. I did his hand fellowship at the University of Pennsylvania. Welcome, Dr. Jehle.
Thank you. Nice to be here. Thank you for having me.
Great. Well, gosh, we are going to talk about some interesting and common hand problems today. And as plastic surgeons talking about hand surgery, that may confuse some people who typically think of hand surgeons as orthopedic surgeons. Could you kind of clear up that issue and tell us a little bit about that and also how somebody becomes a hand surgeon?
Yeah, absolutely. Actually, that comes up a lot in clinic because patients will be seeing their primary care doctor or somebody and be referred to a hand surgeon and be a little surprised when they show up to a plastic surgery department.
Absolutely.
The history of hand surgery is fascinating, and a lot of it kind of is derived from there.
Mm-hmm.
A lot of plastic surgery was derived out of wartime, and hand surgery is no different. They found that a lot of soldiers were having hand surgery and they would require an orthopedist, sometimes a neurosurgeon, sometimes a plastic surgeon to all do different components. And essentially, they all looked at each other and thought, why don't we just teach each other these different components and refine surgery at the level of the hand or upper extremity? And one of the people who had done that was a plastic surgeon. And a lot of that flowed from there. And so in some countries like Canada, almost all of hand surgery is done by a plastic surgeon. In some countries like America, more hand surgery is done by orthopedic surgeons, but even still about a third of hand surgery in this country is done by plastic surgery.
Yeah.
And in training, we actually go through the same exact process at the fellowship level and have the same accreditation. So
Yeah, that's great. And actually, I'm a fellowship-trained hand surgeon myself, too, so I know exactly what you're talking about, and I loved it.
yeah.
I want to ask you about some of the various categories of hand anatomy or function that a hand surgeon may treat, regardless of whether or not they're an orthopedic surgeon or a plastic surgeon.
Yes.
What are some of those components of the hand or general category problems of the hand that a hand surgeon might treat?
Yeah, so a hand surgeon treats a variety of issues. There are congenital issues that some children are born with congenital hand differences.
Mm-hmm.
So some children are born with their fingers that are still fused together, and a pediatric hand surgeon might either separate the fingers out, or sometimes children are born without a thumb or other digits and can actually reconstruct those digits.
Yeah.
In addition to congenital issues, trauma is something that is very common. About a fifth of all ER visits for trauma are trauma of the hand or upper extremity.
Yeah. So injuries is what you mean by trauma.
Absolutely. It can be as small as working in your kitchen and accidentally cutting your finger with, a kitchen knife. It could be as large as a motorcycle accident or something that requires more extensive reconstruction.
Hmm.
So, in addition to injuries, arthritis or other kind of degenerative conditions where wear and tear has taken its toll on the hand and is starting to interfere with function. And reconstruction is another area of hand surgery. So, whether somebody has a soft tissue cancer like a sarcoma,
Yeah.
which might require more extensive muscle reconstruction or nerve reconstruction, or more superficially, skin cancers are very commonly found on the hand, and
Yes.
being able to reconstruct that is really important to make sure function is maintained.
Yeah. And even transplants for reconstruction, too, right? I don't know if you've been involved with any, but
That's right. Actually, where I trained in Philadelphia is one of the few hand transplant centers, and thankfully they don't come around very often for patients,
yeah.
but when they do, being able to bring more function through a hand transplant is one of the kind of pioneering fields of hand surgery right now.
Yeah. Gosh. Well, I'd like to ask you, as a plastic surgeon, hand surgeon, how much of your practice involves the hand? Are there other plastic procedures that you're doing, or what does your practice makeup look like?
Yeah, that's a great question. And in classic plastic surgery fashion, nothing is completely black and white. It depends a little bit on where you want to stop calling something a hand.
Yeah, that's true.
But about, yeah, two-thirds to three-quarters of my practice is either hand, or a lot of places will categorize peripheral nerve surgery. So the
Hmm.
nerves after they've left our spinal
Yeah.
cord.
So
And
it could be in the arm or forearm and not just the hand proper.
That's exactly right. And even sometimes the lower extremity. So carpal tunnel syndrome, something we're all familiar with, and I think we'll talk about today, but there are even some compressions in nerves of the lower extremity that are treated by plastic surgeons and myself.
Yeah, very good. Well, I'm curious what actually inspired you to become a hand surgeon.
So I was inspired to become a hand surgeon in residency. So I actually didn't know exactly what I wanted to do and thought that I would be kind of a generalist throughout residency, and really took to how functionally based the surgery is. So lots of elements of plastic surgery are all about, details. And when you think about surgery on the face, there are, many different anatomic structures of multiple tissue types in very close proximity, and the little details matter a lot. It's very similar in hand. The difference I found that appealed to me was, while the aesthetics are still an important component to plastic surgery, having a gentleman come in who wants to be able to play the guitar again, having somebody who crochets or cross stitches who's unable to, but you're able to restore that function, I found very rewarding. So that's what really drew me to it.
Absolutely. Speaking from my own personal experience, I loved the intricate nature of the anatomy, and it was such a confined space, but every little thing had its perfect function. They all fit together beautifully, and when one thing goes a little haywire, it can really set other things off. I just thought it was fascinating. So I share your love of hand surgery.
I agree.
Yeah, gosh. Well, today we are going to talk about some of the more common hand problems that may affect people, and we're going to talk about the treatment options for those. So, specifically, we'll cover carpal tunnel syndrome, trigger finger, ganglion cysts. Gosh, there's so many others we could talk about, but we've got to limit it somewhere. But I'd like to start with carpal tunnel syndrome. Could you explain for the listeners what the typical symptoms are, and then what is really going on in the hand or wrist to create those symptoms?
Yeah. So carpal tunnel syndrome often will show up with numbness and tingling, usually in three fingers or thumb, index, and middle finger.
Hmm.
Sometimes the ring finger's involved. And a lot of times patients will first start noticing it either at night when they're sleeping, or with certain activities like driving, or if their hand is in a flexed position, and usually starts out pretty minor. And these might wake a patient up from sleep. They might say, it feels like I have to shake my hand out, run it under warm water. And as time goes on, they might develop other symptoms like clumsiness or feeling of weakness in their hand.
Hmm.
And sometimes that kind of episodic nature will kind of change to being around the clock. And so that numbness or tingling kind of fuzziness sticks around.
Yeah.
Patients might describe it as feeling as though they're kind of feeling the world through cloth or leather and just not having that same level of dexterity and feeling that they had before.
Yeah.
What carpal tunnel syndrome actually is pressure on one of the nerves that gives us feeling to those three fingers
Mm-hmm.
and gives us the strength to the muscle of our thumb. And so anything that puts pressure on that nerve can actually cause the carpal tunnel syndrome. So typically, that nerve and nine tendons are running through a very tight space in our wrist
Called the carpal tunnel.
called the carpal tunnel. Exactly right. And we've got this really tight ligament that holds all those in place. Now, every mammal actually has that ligament in their upper extremity, and it's probably more important for animals that walk on all fours.
Mm.
But in humans, it really seems to be kind of constraining those tendons and that nerve, and anything that causes swelling in those tendons can press in on that nerve, which is the softest, spongiest tissue inside of there, and then that blood flow gets cut off. And when the blood
Mm.
flow gets cut off, it falls asleep. And that's why if you feel like you got to shake it out
Mm-hmm.
or do something to bring that blood flow back. So, in my patients who are diabetic, that's a very common reason to have tissues hold on to a little bit more fluid. I usually can kind of blame that.
Mm-hmm.
Thyroid conditions can cause something very similar where you're holding on to more fluid. Pregnancy is actually a very common cause of carpal tunnel syndrome, and in fact, can
Yes.
sometimes be a reason why carpal tunnel syndrome is temporary. And after the child is born, sometimes those symptoms go away.
Mm-hmm.
And then, more often than not, you have enough birthdays, you've just been using your hands your whole life, and there's a certain finite size to that tunnel. That nerve might just get pressed on just for reasons we don't have anything that we can necessarily peg.
Yeah, that's a good way to put it. Well, how do you diagnose carpal tunnel syndrome?
That's an excellent question. So, diagnosis of carpal tunnel syndrome can have several components. We can use symptoms, usually a constellation of symptoms if it fits.
Kind of classic.
Exactly. And the human body bothers to read the textbook. We can usually diagnose it without any other tests. So that would be things like having it involve those 3 to 3.5 fingers specifically, having symptoms that will wake you up at night, feelings of clumsiness, and then some exam findings. So when I see a patient in my clinic, I'm not just asking questions,
Mm-hmm.
but performing a physical exam. And so when nerves get upset or if they're pressed on, sometimes they'll send these little almost lightning-like zaps in the area that they're upset. So I'll literally tap on that nerve right over where I'm expecting it to be pressed, and sometimes it'll send these little electric-like feelings out. Even just putting a little bit of pressure on it, there's different tests where we can kind of simulate that pressure. And if it makes the symptoms happen, then we can say, well, that's likely the cause of your symptoms.
Mm-hmm.
So in those cases, a lot of times I will not make a patient go get an extra test or have enough information to proceed with treating them for carpal tunnel
Mm-hmm.
syndrome. If they don't seem to have that same textbook presentation, there's one classic test that people will get called an EMG
Yes.
or electrodiagnostic or
Mm-hmm.
electromyogram. These are tests where another physician or technician will place needles into the skin and into the muscles and over the nerves and actually run an electric current. They're actually able to measure the speed at which that current can travel across the nerve, as well as the amplitude or just that signal strength. And if it appears that the strength is either lower or kind of dropping or slowing down across these common pressure points, it can suggest that that nerve is being pressed on in those
Yeah.
locations.
Well, and you say use needles, and it's not that bad. I've had one done myself, and so I will tell the listeners that it sounds worse than it is.
I would completely agree with you. In my training, my mentor had said if we're going to order this test for anybody, we should have it done ourselves.
Is
And
that right?
yeah, so and I trained up in the Northeast where things might have been a little more,
they're,
uh,
they're
you know,
tough up there, you say.
a little tougher. Yeah, so I was able to have the test done, and it wasn't as bad as I was anticipating.
Yeah. Oh gosh.
One interesting update in tests and diagnostics of carpal tunnel syndrome is ultrasound
Yeah.
based diagnosis. So,
Yes.
more and more practitioners like myself are getting an ultrasound machine that they will have in their office, just like at an OBGYN office where they're using that ultrasound to measure and look at the baby and make sure that it's healthy. I can actually use it to look at these nerves and different structures in the hand. As you had said, many different structures, many different tissue types, all in a very small area.
Yeah.
And they've found that if it looks like that nerve has been pressed on for a while, it actually holds on to fluid itself and looks edematous. And so I can
Mm.
measure how big that cross-sectional area of it is, kind of leading up to the carpal tunnel and in the carpal tunnel, and use that as a cutoff. So sometimes I can actually use that rather than make somebody go to another location, get another test, and can
Yeah.
hang the diagnosis on that.
What a great addition to your diagnostic armamentarium. That's wonderful.
Yeah.
Okay, so we've talked about diagnosis. What typically causes or predisposes someone to have carpal tunnel syndrome? We did talk about things like diabetes and pregnancy, and I can't remember if you mentioned thyroid disease, maybe predisposing people to carpal tunnel syndrome. But are there physical activities that might contribute to that development?
Absolutely. There are some physical activities that have been linked to carpal tunnel syndrome. And interestingly, there have been some physical activities that I think in popular culture we think about being linked to carpal tunnel syndrome that might not have as strong a link as we had thought.
Good point.
So things that very commonly will lead to carpal tunnel syndrome are vibratory equipment. And
Mhm.
so classically, somebody who's been using, let's say, a jackhammer, or I've had
Yeah,
somebody who works in the jewelry industry and they had this vibratory device that they're using to hammer out thin pieces of sheet metal,
mm,
which had caused her to develop carpal tunnel syndrome. And then even, and this might be more anecdotal, but kind of making symptoms show up, a lot of motorcycle riders. I think they're sitting on motorcycles and they're vibrating and they say
yeah.
reliably, like, this is not a problem for me in the winter, but as soon as I start riding my Harley, this is becoming a problem. And so usually it can stave it off for a season or two. And then,
Interesting.
yeah. One thing I found very interesting, especially as I was going through training, was that it does not seem to be linked with typing or using a mouse as I had commonly thought it was.
Yeah, tell us more about that because that is a common supposition.
Yeah, exactly. I think potentially the position people put their hands in when they're typing can make pre-existing carpal tunnel syndrome rear its head. So
Mhm.
if you're holding your hands in a specific manner, it might make those fingers fall asleep. But having a lifetime of computer work or typing or using a mouse, as far as we know on the larger population studies, doesn't seem to be linked to causing carpal tunnel syndrome. So it might be correlated with your symptoms, but it's harder to blame your carpal tunnel syndrome on using the keyboard, which can be either freeing for some people or sometimes a little bit of a bummer if they thought that they could hang it on that.
Mhm. Well, once carpal tunnel syndrome is diagnosed, what are the treatment options? Is surgery always necessary, or how do you choose what type of treatment you're going to offer a patient?
So, surgery is not necessarily always necessary. So, carpal tunnel syndrome can be mild, and I have a lot of patients who really only have symptoms at night, and so they're bothered mostly by waking up with that numbness and tingling. If they haven't tried splints, I will actually try splints, and that tends to be a very effective manner. It actually holds the hand in a position where it's not having pressure on the nerve, and in those
Mm-hmm.
patients it alleviates those symptoms. That's all that they need. Other times patients can do non-operative management if it seems to be more of a temporary reason that the nerve is being pressed on.
Right, right, right.
So the classic example is my patients who are currently pregnant, and we know that that baby is going to be delivered eventually. And I'll sometimes put a steroid injection into the carpal tunnel itself, which itself is a medicine that calms down inflammation. And if it takes just enough pressure off that nerve while the body's holding onto more fluid, it can treat carpal tunnel for the duration that's necessary, not have to do any sort of surgery.
Good temporizer.
Yeah.
And I did have, I'm sure you've had this too. I had patients who, once they heard the word steroid, they thought, oh no, I don't want steroids in my body and da da da. You know, you hear all the bodybuilders who use steroids,
Yeah.
that sort of thing. What do you tell your patients when they raise those concerns?
Yeah, I talked to them about how steroids are a very large class of medications, and not all of them are the same. In this particular case, they're a medicine that decreases inflammation. It's a different family than something like ibuprofen, and it works very effectively. And in fact, the injections that we give act locally. The one that I use is almost opaque. It looks kind of milky in the syringe, and that's because it's a solute or it's a molecule that sticks around in the area that I inject it, which I'd much prefer over giving a patient an oral steroid that's going to act on every cell in their body and cause a lot
Yeah,
more side effects
yeah,
elsewhere. So
yeah,
typically it's very favorable to have an injection of it, even though people don't like needles. That's normal. I mean,
yeah. You can mix it with numbing medicine.
exactly. And I always do, and use a little cold spray, and you know, almost 100% of people say, that's it. that wasn't bad at all. Like, I thought it
Yeah.
was going to be way worse. The anticipation was the worst part.
Yeah,
So,
especially if it's an alternative potentially to surgery. I think
yeah,
they many times are willing to try that.
yeah.
Uh, how many steroid injections do you feel comfortable letting someone have over a period of time before you say, hey, we really need to proceed surgically here?
Yeah. So those steroid actual molecules are there working for about 3 months, more or less. So I feel uneasy if the symptoms come back before that time, just trying to do the same thing again, and put more of that medicine in the area. So if I try not to inject anything sooner than about 3 months. Now, there's a certain element of depends on how long of relief that one gets from a steroid injection. If it feels better for a whole year, I might do a steroid injection every year for 2, 3, 4 years. But at a certain point, doing the same thing over and over again and expecting, the result to be durable or permanent, I start counseling more on the intervention side, especially for carpal tunnel, where steroid injections are almost always temporary and the treatment is almost always permanent and the risks are very low.
And then when you do proceed to surgery, what are you trying to accomplish with the surgery? What are you physically doing in there?
Yeah, so the surgery itself, that ligament that's pushing down on the carpal tunnel itself that contains those tendons and nerves is just released. So I think a lot of patients believe that we're taking something out or we're doing something with the nerve itself. You actually just release that pressure on the nerve by
Hmm.
taking the ligament and like you would basically cut the rubber band and
Yes.
allow it to kind of open up. So
Yeah.
that's really the entire procedure is taking the pressure off the nerve by cutting that ligament that's sitting over it.
Yeah. What kind of improvement can patients expect? Are they fully recovered back to normal then, or partial recovery? And if they are fully recovered, is there a risk of recurrence, or what do you find in your practice?
Yeah, that's a great question and something that I always go over with patients to begin with. It depends a little bit on how long symptoms have been going on, their severity, and whether the symptoms are there around the clock or if they come and go. So in my patients who have symptoms that come and go and are interfering with just their normal activities and the things they like to do and need to do, those symptoms usually get better quite quickly. So I take stitches out around 2 weeks. Almost everybody says, "Okay, I'm sleeping through the night now and it's not waking me up. I'm
Nice.
noticing a difference." Now, patients who have symptoms where that fuzziness or numbness is there around the clock, it can take longer for that nerve to wake up. And depending on how much pressure and how much time has been on that nerve, sometimes it doesn't wake completely up. And
Mm.
it's hard to predict exactly who is going to have full recovery and who might still have some residual symptoms. Now, one severe symptom that one can get from carpal tunnel syndrome is actually the muscles themselves of the thumb, which that nerve gives power to, can actually atrophy. And it's kind of like a plug-in in a wall socket. If it's been going on long enough, the nerve essentially unplugs from that muscle and it might not ever come back completely. So I usually
Mm-hmm.
will warn patients ahead of time, if that muscle's weak, I have no restrictions. I want you using it. Try to bulk up at what you have, but
Mm-hmm.
it's not certain how much is going to come back.
Yeah. Well, that's good for patients to know. So that's a great coverage of carpal tunnel syndrome. Let's move on to trigger finger. Just by the title, what is it? Does it come from firing a gun? Could you explain what it is and what the symptoms are and why they develop?
Yeah, that's a great question too, because I very often I'll be taking care of somebody who says, I don't fire a gun, or
Yeah, right.
sometimes I'll take care of people who do fire guns and they say, I don't use that finger to fire a gun. This is my ring
Right.
finger. And I said, well, it's not
Yeah.
not really from, using a trigger. It's just that it's triggering or
I think people develop that name because it catches like a snap. It's like a snappy catch, and that's kind of like a trigger. You pull a trigger and you get a snappy catch sensation from it. Yeah.
and a lot of times, like many other conditions, it doesn't necessarily start out with that catching or locking. It sometimes will just start out with some pain and tenderness in that kind of first knuckle of the hand. So where the hand meets the finger, usually on the palm side. And, it will kind of ache, or if a patient's gripping something, they'll say, oh, it just really kind of hurts on the palm side of that first knuckle where my finger meets the hand. And if it's left to go on long enough, not unlike carpal tunnel, that the tendon itself gets swelling in it, and a little bit of edema, and then it starts rubbing on the pulleys that keep the tendon close to the bone. So the way
Mm,
I think about it, and the way I often describe it to patients, is the system that pulls the fingers down is kind of like a fishing pole, where the bones are the pole itself, and these pulleys are kind of like the eyelets on a fishing pole that keep that fishing line or that tendon really close to the bone. If there's no knot in the fishing line and it's gliding normally, there's no issue. But if something happens where that line either gets knotted up, or in this case, that tendon swells up a little bit, it starts creating a little bit of friction on that pulley, which then
yes.
causes some inflammation, which causes more swelling, which causes more catching. And so, trigger finger really, in my eyes, is this positive feedback loop. So, like this kind of cycle of inflammation that's very hard to escape. And so treatment is really aimed at trying to stop that cycle from
Hmm.
continuing. Because as it goes from the pain in that part of the hand, it will start kind of catching, or you'll be using the hand and you'll feel kind of a click, or it will catch. And if it continues to progress, that tendon gets so swollen it actually bumps up against the pulley, and you might need to use your other hand to even open that finger up, or you might be able to kind of pop it out on your own. And then, if left long
Hmm.
enough, it can develop into a trigger finger that's so severe that the finger's never able, it's not able to make its full range of motion despite what you do. By that time, you shouldn't have waited so long to see somebody by that point.
Right, right. Yeah, it's kind of like the tendon gets stuck in there and just can't
Yeah.
move in any direction. So, yeah. So, on exam, you started to talk about tenderness in that area. Is there anything else that might be appreciated on exam that would help you diagnose it?
When I see a patient with a trigger finger, I'll usually start on digits that aren't bothering him at that time and press in that same location. It's just right over the kind of the bony part of the palm where it meets the finger, and start working my way over to the finger that is causing issues. And then I can reliably usually find some tenderness there. I will actually use my finger, and a lot of times you can feel the tendon itself is a little bit swollen. It feels like a little onion bulb or a little knot in that tendon moving back and forth.
Yes.
If a patient's able to demonstrate that catching or triggering or locking, I usually ask them to show me, and then by that time, the diagnosis is pretty clear. There's not many other things that show up that sort of way. And it's more about explaining, oh, I know it feels like that second knuckle is the one catching and moving, but interesting, the problem starts a little bit lower. It starts in the hand and kind of shows up in the joint in the finger.
When I would examine a patient, I would often find that little onion bulb or nodule that you can feel near the pulley as the finger is moving. And then I would put the patient's other finger on that, and they could feel it move. And they're like, whoa, that is
Yeah.
crazy. So I think they understand it better once they feel that.
I love doing the exact same thing. And if you can do nothing more than at least help a patient understand what's going on, it really
Yeah.
helps frame any recommendation that you make for trying to improve it. And so I do the same thing, and it makes a lot of sense, that visualization of either the fishing pole, or understanding that that knot or that onion bulb is physically kind of abutting something and stopping it from moving. So
Yeah, I think that's great. Well, how is it best treated? And again, is it a spectrum of options you have for treatment, or how do you approach treatment for a patient?
yeah, treatment is similar to carpal tunnel syndrome in that you can, on the conservative side, try to avoid any sort of pokes or prods by splinting things, really giving that pulley system a rest by
Mm.
splinting the finger out open. Some patients who are averse to trying a steroid injection, I'll use like a topical ibuprofen called Voltaren,
Oh, yes, a little
and
gel.
try that exactly. And frankly, sometimes that will work, and sometimes patients will come in with some pretty ingenious homemade splints and things where they'll stave off a trigger finger for a long
Is
time.
that
And
right?
yeah,
Get creative.
that's exactly right. And if that doesn't work, it's not that there's no hope. I usually recommend trying a steroid injection for trigger finger, because
Hmm.
it tends to be really effective, and in a way that steroid injections for, let's say, shoulder arthritis or knee arthritis or hip arthritis, where patients who have trigger fingers sometimes will have had an injection like that. it can sometimes cure a trigger finger. So
Hmm.
it's more that tendon is unhappy due to either kind of being used for gardening or kind of was run through the ringer for one reason or another. And if you can
Yeah.
just break that cycle, it'll go back to normal. And so I'll almost always try to recommend a steroid injection before jumping to a surgical or procedural intervention. Statistically, I think it's depending on the reason for it, about 75% effective, and it will go away
Yeah.
without any sort of operation.
Yeah, that's remarkable compared to a lot of hand ailments. So it's really pretty great. If you do decide someone needs surgery, or if the problem just keeps coming back after a steroid injection, what physically do you do in there? What is the goal? What are you trying to accomplish?
Yeah, in that case, when you have binding of that tendon and the pulley system, I just release the pulley itself. So the finger has some redundancy. There's multiple pulleys that hold that tendon close to the finger.
So you can sacrifice one and you're okay.
That's exactly right. And so I like going over just right over where that pulley is, and it makes a very acute bend where the finger meets the hand, and that's probably why that pulley in general is the problem child, but I don't
Yeah.
really do anything to the tendon itself. The previous kind of thought was, well, if you can just debulk that tendon, it would slide through the pulley really well. And then somebody, ingeniously thought, well, what if we just release this pulley? Will it cause any problems? And for the most part, it does not. So if it can't bind on that pulley, it calms down that cycle. So it's again like the carpal tunnel, not taking anything out, just releasing that ligament that's binding up with the tendon.
Yeah. Well, and if you have a trigger finger in one finger, let's say that's been treated, can you get other fingers that develop a trigger finger? Maybe even multiple fingers. Is there some significance to that?
Yeah, so if I have a patient who now has multiple trigger fingers either showing up at the same time, or if they'd previously had a trigger finger and it was treated with a steroid maybe a year or two ago, now there's another tendon that's bothering them, I start wondering if there's something kind of systemic that's causing those tendons to be more inflamed. So just like the carpal tunnel, anything can make tendons edematous or hold on to fluid can cause trigger finger. So commonly
Hmm.
patients with diabetes, again, thyroid disease, patients with rheumatoid arthritis or some other autoimmune condition can have that swelling in those type of tissues and cause trigger fingers. So I start wondering if they don't already carry that diagnosis, if maybe there's something like that going on.
Yeah. It's good to check for that in those situations. Well, gosh, we're covering some great ground here. We've talked about carpal tunnel syndrome. We've talked about trigger finger. Lastly, I want to talk about the ganglion cyst. What are ganglion cysts, and where do they typically occur?
Really, just the three of these issues total, I'm sure 20-30% of people will have either one of these conditions or know somebody in their immediate family with one of them because they are so common.
Yeah.
A ganglion cyst, it's a cyst that's an outpouching of a joint. So they can occur on almost any joint of the body and commonly will occur either in our wrist or sometimes in our finger joints. It can
Hmm.
actually occur off of the tendon sheaths themselves. So ganglion is
Hmm.
kind of the big umbrella term for them. And as any condition that's been around for ages and ages, has developed some other names for it that are like a mucus cyst is a ganglion
Yes.
cyst on that
Yes.
last knuckle, usually by a fingernail, also called a mucoid cyst. Um, People will have retinacular cysts, which is a ganglion cyst off the tendon sheath. People will call the cysts on the top of their wrist a Bible cyst commonly. That was kind of the treatment method that some would use
Right.
to hit it with a heavy
Oh my
book.
God.
But
Yeah.
what it actually is, it's an outpouching of the joint. So I like to think about it. We've all seen a tire that has like a bubble on the sidewall where one of the cords that keeps the integrity of the tire together lets go and you get this outpouching. It's the same in that joint. And so, for whatever reason, whether it's a small trauma, whether it's just time and use, or sometimes bone spur from arthritis, it weakens that joint a little bit. And your body still wants to keep that fluid in, but it kind of pouches out. And so, if you were to sample the fluid inside of that cyst, it would be really thick and clear. It's the synovial fluid that lets our joints and our tendons glide really well. But it also is why they call it a mucus cyst, because if it were to pop,
Hmm.
patients or somebody might look at it and say, "What the heck? Is this snot coming out of my finger?" And
Yeah. It's gooey.
yeah,
And I looked up the word ganglion, the etymology. It originates from the ancient Greek word ganglion, which means knot or swelling.
Yeah.
So, well, that's what it is. Do the causes vary sometimes? Or
So it's not always trauma, it's not always arthritis, it's not always wear and tear, but those are all things that are kind of suggested.
hmm
I see a lot of patients where they didn't do anything as far as they know to injure their wrist or hand. It just happened.
hmm
And so that can be, in medicine, we call that idiopathic, or we don't know why. And that's a very common reason to get them.
hmm Will it show up on an X-ray?
Ganglion cysts don't typically show up on an X-ray, so it's a soft tissue, and X-rays are really excellent for looking at bones and can show the space between the bones. You might see other conditions that are related to the ganglion, which might show up, but typically the ganglion itself won't show up on an X-ray.
So, given that, do you usually recommend, let's say if it's involving a joint, do you usually recommend a patient get an X-ray, or do you find that the yield is so low that you just don't even bother?
Yeah, it depends. A lot of times I'll see the patient before deciding on whether or not to get an X-ray. So if,
hmm
I have an 18-year-old girl and they're seeing me in clinic for this bump on the back of their wrist, I typically won't get an X-ray if they don't have history of a trauma or hip, anything that we can really point on. I'll
hmm
usually sort that as idiopathic because the chances of seeing anything on an X-ray that would change management are very, very low.
Given all of that, what are the treatment choices for a ganglion cyst? I mean, should you hit it with a Bible?
I typically recommend against that.
Yes.
You will meet patients or their family members who have done that and successfully made a ganglion go away. I don't recommend that exact treatment.
I was going to say it's a great way to break a bone, too.
Yeah, exactly. And then all of a sudden we are x-raying and fixing broken bones. The clinic way of hitting it with a book is actually putting a needle and draining the fluid from it. That's called aspiration.
Yes. Much more civilized.
Yes, exactly. More controlled method of treating these ganglion cysts. And depending on their location, I'll utilize the ultrasound machine as well. So on
Oh,
the
yeah.
on
That'd be great use for it.
yeah, it feels more comfortable being able to see what's going on underneath the skin, particularly on the palm side of the wrist, because we have multiple nerves and usually an artery that's running quite close to where that cyst
Mm-hmm.
is. And um, I would feel uncomfortable just blindly placing a needle in those sort of areas. On the top of the wrist, there are fewer things that you could potentially injure and just less tissue between the outside world and that cyst, and it's reasonable. But on that palm side, it's really nice to use an ultrasound. Now, when you do that,
Yeah.
I do try to get a little bit of bleeding into that cyst wall because what you're trying to do is deflate it and then hopefully have that the wall around it kind of stick together so that it doesn't recur.
After it collapses. Yeah.
Yeah.
Do these tend to come back? What do you tell patients in terms of what to expect?
So it depends on what intervention. If you
True.
stick a needle in it and it's been there for maybe 1 or 2 months, the chances of it coming back are a little bit lower than if you stick it into a cyst and drain the fluid that might have been there for multiple years. Like the theory that wall has developed a little bit thicker substance to it, and it might even be that the passage between the joint and that cyst is a little bit more developed, and the chances of it collapsing down and staying down are a little bit lower.
Mm-hmm.
Overall, the chances of it coming back, if you were to just take the fluid out of it, are pretty high. So, probably about 3 out of 4 come back.
Ah,
However, it's easy to do in the office. It's safe. It's a sterile procedure, and the chances aren't 100%. So it's reasonable to try. And the other benefit is you also achieve a diagnosis with that as well. So
yeah, that's nice.
you're able to say with certainty that it is a ganglion cyst.
So if it comes back, we know what to do.
Correct.
And if you do treat it surgically, what are you physically doing in there?
So if you treat it surgically, you want to remove the entire cyst wall as well as that little stalk going down into the joint itself because it is an outpouching of that joint.
Yeah.
And I make basically a little box out of that joint. And if I can cauterize the edges or use a little heat to try to make the body scar that tissue in, that will give it the
Mm-hmm.
the lowest possible chance of coming back. And if the ganglion is coming off of a finger, I'll usually look and see if there's a small bone spur or some arthritis that might be able to be removed to decrease the chances of it coming back.
Yeah. Maybe the irritation from that bone spur was causing the ganglion cyst, you're saying.
Yeah, exactly. So if you can remove that underlying cause, that's another adjunct to removal that can help the chances of it coming back.
Perfect. Well, so we've covered these great topics, these very common hand problems. I would imagine that the surgical experience for the patient is relatively similar for all of these. Could you kind of go through what a patient would experience when they're having these surgical procedures done? Where is it done? What type of anesthesia?
Yeah, so again, everything in life is on a spectrum. And if you want to call the surgeries, I think a lot of patients think about being in an operating room, being completely under general anesthesia where they don't even remember seeing an operating room, which is becoming less and less common for these type of conditions. A lot of times when I'm talking to patients, I'll actually refer to them more as procedures
Mm-hmm.
rather than a full surgery because myself and a large number of people in the United States and very much in Canada and other places have been doing this with the patients wide awake in an office-based setting. So it's not
Mm-hmm.
universally the case, but a lot of providers are now doing these with the patient awake. So they'll come to wherever they're having the procedure done, always involves some level of local anesthesia. So some places will put a shot kind of up in and around the shoulder to make the whole arm fall asleep.
Mm-hmm.
Sometimes they'll put an IV in and put that same local anesthesia through the veins and through use of a tourniquet allow the area that's being operated on to fall asleep. Or what I'll do is I'll just put one small injection kind of in the forearm area, just past where the hand is, and make the area that we're working on fall asleep. And then universally, the hand or wrist is prepared with an antibiotic, either soap or kind of alcohol-based treatment to sterilize the skin. And then sterile equipment is used after everything's draped out to cut through the skin, get down to the ligament or the ganglion or that pulley in the case of the trigger finger,
Mm-hmm.
and release
Mm-hmm.
it. And then the skin's usually sewn closed with stitches that come out in about 1 to 2 weeks.
And traditionally, hand surgeries or procedures have often been done with a tourniquet on the upper arm so that there's no bleeding during surgery, so that the surgeon can see all the little teeny structures we talked about and make sure they're not harming anything and injuring something they don't want to. But tell us about this concept of doing these hand surgeries and hand procedures without a tourniquet and just using the local anesthetic you were speaking about, and the patient wide awake and can talk to you.
Yeah. So most patients will actually be good candidates for this type of surgery because it doesn't require patients from stopping medications that they're taking. A lot of times that
Mm-hmm.
even includes blood thinners. And that's because the anesthetic also has a medicine in it that constricts the blood vessels or makes all the little blood vessels tighten up so that there isn't so much bleeding.
Mm-hmm.
It's been found for most patients that it's a very, very safe type of anesthesia to use in the hand and fingers. And that way you don't have that sort of bleeding. And that combined with the small retractors that are used, it holds the tissue out of the way because, as you intimated, being able to see everything that you're doing when you're working on such small structures is of paramount importance. So it's not that we're going in there blind, it's that we've come up with ways of being able to see everything that you're doing without having to put a tourniquet on, which can be uncomfortable.
They really can. After a while, they get very uncomfortable. And that's one of the reasons that a lot of patients will get a little bit of relaxing medicine through their IV or a little sedation or that kind of, or even go to sleep because that tourniquet can be so uncomfortable. And so doing it with this relatively newer technique, now it's been around for a while, but doing it this way can really be a wonderful adjunct, an option for patients. And the technique we're talking about is the mnemonic is Wallant. It's WALANT. So wide awake local anesthesia with no tourniquet. And that's typically how you do your procedures, right?
Correct. For most of these procedures that can be done in the office, I will do this technique. Makes the patient happy and makes the experience that much easier for everybody.
Yeah, that's so great. All right. We have talked about some common problems and we've really covered a lot of ground. But as we finish, I just want to take a step back and maybe even get a little philosophical. dare I ask, what do you think the future holds for hand surgery? Are there some advances you foresee, or is there anything you would like to see? Maybe we don't even have a technological path for yet. Curious what your thoughts are.
Yeah, I think there are a couple areas that both in the near term and then the longer term we'll see. I think there will always be conditions that need to be treated and probably need to be treated with some sort of physical intervention. So
Yeah.
carpal tunnel syndrome is probably one of those. There have been efforts to make the actual procedures themselves less invasive.
Hmm.
There's some work on doing it based on just a small poke that doesn't even require stitches and using a device that can be seen with that ultrasound to release the ligament. And I think you'll see some improvements in the near term with that. I think long term, especially when we think about trauma and injuries and arthritis, those will be two areas that a lot of attention is being turned towards. So
Mm.
regenerative medicine is a topic in general that people have been thinking about for dozens of years.
Yes.
And, how do we turn back the clock? How do we grow new cartilage? Because cartilage is kind of like tread on a tires. You're born with a certain amount, and depending on what sort of miles you put on your joints, if it wears out, there's not a whole lot we can do reliably with a lot of, large scale trials to grow that back. So
Yeah.
that's one area where there's a lot of interest in, death, taxes, and if you live long enough, arthritis is going to be part of everybody's
Right.
life. So if we can do something about that,
Yeah.
it would make a big difference. The field of nerve regeneration is
Yes.
one where there's a lot of research being done to see how nerves can be put back together, but then importantly, once they are put back together, coach them to recover quick enough that they can reach those muscles before they unplug, like we had talked about
Yeah.
before.
Yeah.
So I think those are certain areas where we'll be looking in hand surgery for answers.
Yeah. I think that's great insight. Thank you for sharing that. Gosh, well, Dr. Jehle, thank you so much for spending some time with us today and providing your expertise. I think it's been really beneficial for the listeners. Thank you. Anything else you want to add?
Oh, it's my pleasure. No, I could sit and talk about hand surgery things indefinitely. I love it. I
Yay.
think just letting people know that plastic surgery is not just a pioneer in hand surgery, but day in and day out, a purveyor of hand surgery and being able to solve problems to get people back to doing the things they like to do and need to do is what keeps me coming into work. I love it.
Love that. All right. Well, thank you so much and take care.
Thank you.
Well, that's our show for today. Hope you enjoyed it and learned something too. Don't forget to subscribe, rate, and review. Please share this podcast with someone else who might be interested. And while you're at it, check out the podcast website for related topics to explore. It's www.plasticsurgerydecoded.com. And as always, thank you for listening to Plastic Surgery Decoded.